Okay, so this is a lecture of mine that is going to fill in just a couple gaps in things that I want you to know for our acquired neurogenic disorders section. The next one is aphasia is what it's called, but it's TBI and aphasia is basically what it's about. But it's all under the acquired neurogenic disorders label. So what does acquired neurogenic disorders mean? Well, acquired, you should know, right, comes from something that happens after you've been born, right? So it's not something you're born with. It's not a congenital defect of any kind. It's something that you've acquired over time. Neurogenic, well, neuro means brain, and genic means this is where it comes from. So this is a disorder that comes from the brain. It's something that's localized in the brain. So it's a type of disorder that you have gotten later in life and affects the brain, or is centered in the brain. So typically, I mean, in terms of our profession, SLPs, AUDs, and then if you want to be a researcher as well, we're kind of concerned with the fact that these are language issues. So they have something to do with usually either the cognitive or perceptual part of language. And the reason why they have something to do with the cognitive and perceptual portion is because it's brain-centric, so it's not an effector problem, right? I mean, sometimes you can have things that are strictly effector problems. You can acquire let's say a paralysis of some of the muscles that move the mouth. And that could have come from a stroke, but it wouldn't necessarily be a neurogenic disorder, because if it's just a paralysis of, let's say, the facial muscles, all of the language skills are still intact. So, I mean, it's still acquired, not neurogenic. It would be an acquired kind of structural disorder, right? Because you'd have this paralyzed facial structure. So anyway, typically when we're talking about neurogenic, it's going to be the higher levels of language, things that aren't just the purely motor process of speech. So these can come from a variety of different areas. Traumatic brain injury, which is TBI, that's a huge one. I mean, you can get TBI. There's a few different kinds of TBI, which I think we're going to talk about in the next lecture, but if we don't, I'll go through them now. And have open or closed injuries. So a closed injury would be something like car crashes. You get TBI in car crashes a lot. Motorcycle crashes, especially, even bicycle crashes. If you're not wearing a helmet, you can end up with TBI. So these are usually kind of blunt force injuries to the head, and they can cause damage, swelling, bleeding in the brain, and that's TBI. An open injury or a penetrative injury is something where something's actually gone, into the brain and taken out an area or damaged an area. This could be, bullets. It could be things, going places. One aspect of this is a lot of times people who have been in the military can end up with TBI from shrapnel from IEDs. So any sort of thing that goes into the brain, you stand a risk of sustaining TBI from that as well. Stroke is another one. So a stroke we'll definitely talk about in the next lecture, but it's going to either be an occlusion of blood or the blood vessel has actually ruptured. And so what happens is the portions of the brain served by those vessels go without blood. So they're not served with blood, so they kind of die, right? The neural connections might begin to wither because there isn't enough blood getting to them. Now, this is an interesting thing. If you've taken my 310 class, or if you are going to take my 310 class, we talk about this, that you can hold your breath for a long time, You can hold your breath for, I can hold my breath for over a minute. Some people can hold their breath for over 2 minutes. There's like some total nut cases that do it for like 5. So you can go without oxygen. Your body can go without taking in new oxygen for a long time. The reason why that's true is because there's still stored oxygen in the lungs, and the lungs are still trading out the gases and oxygenating the blood. And depending on your lung capacity, depending on how healthy your lungs are, you can exchange the gas pretty readily. You might feel like you need to breathe, but actually you don't really. There is enough oxygen still there to keep oxygenating the blood. However, the brain can't be without oxygenated blood for very long. I forget my exact number, but it's somewhere around 15 seconds is enough to cause brain damage. So we can hold our breath for longer than 15 seconds, but there's still oxygen there. There's still blood that can be oxygenated. If you occlude blood flow, however, from an area in the brain for 15 seconds, you can end up with brain damage. That seems like a very short amount of time, and it is. That's not a long amount of time at all. So swelling in foreign bodies, what I mean by foreign bodies is not something in the brain that comes from outside. I mean foreign bodies like tumors. What I've got pictured here, this is a neuroblastoma, I believe. This is one that we saw when I was doing some work at Barrow. And this is the tumor right here. This whole huge thing. Now, you can see, I know you probably don't know a whole lot about the landmarks of the brain yet. You will when you take 310. But this right here, these are called the ventricles. This is where cerebrospinal fluid is produced, and it also runs through there to get nutrients to the brain. They should be approximately symmetrical. So this person should have ventricles like this over here on this side. And they don't, because this tumor is just like kind of squishing those out of there. And you can see that this pervades throughout the brain. These are all different levels of the brain. So one slice might be here, the next one's a little bit up, the next one's a little bit, let's see, let's see if I can remember this. A is about here, B is about here, C is towards the top of the head, D and E are lower. Yeah, D and E are lower. So this is going up, and then this is below the tumor. So A is kind of where it starts, B and C are above, D and E are below. So we've got this neuroblastoma here, and you can see that there's swelling out here on the head. This is, the outside of the person's head. The skin is swollen. Probably, if I could see where the bone is, I would assume that it's swollen as well. So this is a huge blastoma. You can see here that the ventricles are squished over here as well. There's some indentation. Something strange is going on with the brain tissue right in this region as well. I would assume that this is swelling. This is, fluid that's accumulated and is kind of then pushing in on the brain. So you've got this blastoma here, and then fluid here pushing on this frontal region of the brain. This is another view of it, another view, and you can just see that this kind of pervades through most of the brain. And then we've also got neurodegenerative diseases like dementia, Alzheimer's, things like that. Those are also neurogenic disorders that can have implications for speech. We're still not 100% sure what causes a lot of these. I mean, we think that it's beta amyloid plaques. You've probably heard a lot of discussion about this. There was recently a study. This is so interesting. So we noticed that we look at brains of people who have Alzheimer's disease, and they have a lot more beta amyloid plaques. So we think, it's beta amyloid plaques. If you have a lot of beta amyloids, you probably are going to get Alzheimer's disease. But there is a group of nuns in Italy, I believe, who have a very low incidence of Alzheimer's disease. And they donated their brains to science, so when they die, we're able to look at their brains and see what's going on in them. And the scientists who are looking at this noticed that they have a lot of beta amyloid plaques as well. In fact, more than some people who have advanced Alzheimer's disease. And yet, these nuns have no Alzheimer's disease. So it might not be beta amyloid plaques. It could be something else interacting with beta amyloid plaques. It could be something else entirely. We don't really know. So anyway, those are another thing that can cause these acquired neurogenic disorders, dementia, Alzheimer's, things like that. Like I said, we're not 100% sure what causes it, although there is some brain shrinkage with these as well. Those we talked about in the ASD lecture. There's also some brain shrinkage in general with age too. So it could be faster shrinkage than usual. It could be shrinkage in a different lobe, possibly. So we're not completely sure on the mechanism that drives those. So here's a penetrating injury. This is one of the most famous penetrating injuries that I know of. This guy's name is Phineas Gage. And so here's a cool story that most people don't tell you. And it's not because, I think it's kind of like, it's hidden in history. Because the cool, like the scientifically cool thing is that he had a rail spike driven through his head and he lived. But there's more to the story that is just kind of bizarre. Okay, so what we know, I mean, the thing that you'll hear a lot about is rail spike through the head. I don't remember exactly why there were dynamite involved with rail spikes. I don't know. Maybe it's common. I've never built a railroad. I have no idea. But somehow there's dynamite and there's railroad spikes, and this guy hit one like to pack it down, and it shot up, and it went, you can see it went like under this zygomatic bone here, which if you don't know about that, again, 310, you're going to know all these bones. So it goes about under there, right behind the eye socket. I believe he's lost his eye from this injury. And you can kind of see, it looks like there's something a little wonky between these two eyes. So it should be this one that's lost. It's probably a glass eye. Although photographs from that time, eyes always look kind of weird. So maybe the glass eye was really good and you couldn't tell. Anyway, so it goes up behind the eye and then out the top of the head. Okay, so here's the story that has gotten lost in history, sort of. So the rail spike goes in and it comes out. He falls down. Everybody's like, oh, Phineas is dead. So there's a surgeon that's, I don't know if he's a surgeon. He's a doctor of some sort. He's like a medic on site, right? So he comes over and he notices that Phineas Gage is still breathing. And he's like, whoa, this dude's still breathing. So here's what he does. He then decides to put his finger inside this guy's brain. I don't know why. Maybe because he's never been presented with this opportunity before. And he like pokes the brain. And it's in his medical writings about after this. He's like, I was actually able to palpate the brain. And you kind of think like, maybe there were other things you should have been doing at this point, like keeping the blood in. But anyway, so he pokes this dude's brain, and he's passed out at the moment. Phineas Gage is passed out at the moment. And as he's like poking around, he comes to, and they rush him to a hospital, and he lives. So that's the crazy part that kind of gets lost, is that this dude decided to poke this guy's brain for some reason. And then it woke him up. So obviously he had nerve damage to the eye. That's like not really surprising. I mean, especially for where this went. It went right behind the eye. This is where the ocular nerve is. It goes up and it comes out. Other than that, he's fine. This is crazy. I mean, physiologically fine. He did have some emotional and personality changes. Everybody said that he was a super nice guy beforehand, and then afterwards he kind of like didn't have a filter. So, he's still kind of nice, but then if he got fed up with something, or if he didn't actually like you, he wouldn't put on the guise of liking you. He'd just be like, "Oh, you suck, get out." And there were some odd speech deficits, but there's not a lot of writing about Phineas Gage's speech deficits because nothing was really able to be pinned down. It wasn't something that was common even to itself. Like, there were sometimes, I believe, I'm trying to remember this correctly, that he would lose the word. So kind of like a tip of the tongue thing, when you can't think of the word that you're looking for. Which is, normal for all of us. I think it happened a little bit more for him, which is a certain type of aphasia that we'll talk about later. And there were some other things too, like sometimes he would get his sentence order jumbled up, but not always. And he would usually catch it and then go back and be fine. And it wasn't an all-the-time thing. I think this was usually when he got kind of run down. So what's really crazy about this is one of the only cases of a penetrating injury where the actual deficits, speech or otherwise, are mostly gone. I'm going to post also a video. It's not a TED Talk. It's a little bit longer than that. But there's a kid who got injured. There's this little, I think it's a boy. Yeah, it's a boy. It's this little boy that got injured, and eventually his whole, half of his brain is gone. You can see the MRI scans. There's no brain on the right side, I think. But he's totally fine. Just using half a brain. You wouldn't be able to see a deficit from the outside. He seems fine, and yet he's missing half a brain. So that's pretty crazy. I'll post that. You don't need to watch it for the exam or anything like that. I'm not going to ask you a question about the video. Just purely for your own interest. If you are curious, take a look at it. It's pretty amazing. Okay, so then I also wanted to talk about concussion. So we know that repeated concussions can cause traumatic brain injury. When this was first brought up in the NFL in 1994, it was kind of like poo-pooed by the NFL, right? If you've seen the movie with Will Smith called Concussion, they weren't really going out on a limb with that title. Then you'll probably kind of know the story, is that this doctor noticed that there's some weirdnesses that are common to the brains of people who, and the behavior of people who have played football or other sports where they have sustained concussions over time. So this concern was raised to the NFL. They gathered an independent panel. I say independent panel because it wasn't really an independent panel. These were doctors that the NFL knew. They choose them. They weren't employed by the NFL per se, but they were friendly to the NFL. And they said that there's no greater risk of long-term neurogenic diseases to players than anybody else in the public. This is what they said 5 years after the first, this was first brought up. They're like, no, there's no difference. They also claim that the players that showed, presented these symptoms actually just had typical dementia. Well, this picture that you're seeing here is, on the top is Alzheimer's disease, typical dementia. On the bottom is chronic traumatic encephalopathy, which is what they call repeated concussion. It's the condition that you can get from repeated concussion. And you can see that it follows a completely different pattern. So what it's showing you here is that blue is where you see initial deficits, then you see secondary deficits in green, tertiary in orange, and final deficits, which would be like before death, in the tan, yellowy, cream-colored part. They should have made these colors more able to be described. Anyway, You can see that with Alzheimer's disease, you get these temporal poles. This is what this area is called here. And then also this frontal region begins there. And then it kind of moves back from there, right? You can see that like green just kind of takes over and moves back from the blue in this area as well. And then you end up with eventually the entire brain. With chronic traumatic encephalopathy, you end up with deficits up here kind of towards the top of the brain and then over on the side. And it's just a completely different trajectory than Alzheimer's disease. So a 2003 study, this is 4 years after the NFL said no, there's no difference, shows that there is probably a difference. And then by 2017, we know that there's probably a difference. I mean, this is when we know that concussion effects aren't the same thing as neurodegenerative diseases. We've fairly well proven that. It's hard to exactly prove it because you don't have two perfect conditions. If you were able to assign people to either have Alzheimer's or multiple concussions, you could say, look, we've done the study, we've proved that these are different, but you can't do that. It's kind of a pseudo-randomized study. You're just pulling people that have these two different diseases and looking for differences. Anyway, there's been enough research so we can fairly well say with a lot of confidence that they're different. But there's still not a whole lot known about the actual trajectory of the disease, the progression of the disease, what we can do to identify when someone has this versus just a typical concussion, although the experts say that, even the first concussion is injury to the brain. One of the things about chronic traumatic encephalopathy is it may not have exact symptoms because it could just be multiple occurrences of damage to the brain. It could just be repeated blows and not have anything that you're going to be able to find and pin down and say this is how it happens. Alzheimer's disease does have pretty identifiable characteristics. These large areas of blue and green, we know that these are evidence of Alzheimer's disease. But it's possible that the other, this is an average of a bunch of different subjects. So is this. But there's a little bit less confidence here. You can kind of see that this region, here, and here. And it's kind of like all over the place. And could be that it's not one exact thing that we could identify and say, you've had multiple concussions. It could just be damage anywhere. And because of that, you might expect a variety of different symptoms because it's just damage to the brain. It's TBI. And as we're going to talk about in the next lecture, TBI is really unpredictable. There's a few different types of aphasias, although no one particular patient that you're going to see eventually in the, when you're practicing is going to fit that textbook definition of a Broca's aphasia or a Wernicke's aphasia or any of those kinds of things, because the brain is kind of it's organized slightly differently for everyone, and so each different area of injury or even the same exact area of injury can cause slightly different deficits for different people. So that's one reason why it's kind of an interesting area. So let's take a quick look at concussion. This is a video that kind of shows the effects of concussion. Oh, I'm going to have to move it over. Hang on.
The brain is the most complex part of the human body. This 3-pound organ is the seat of intelligence, database of memories, interpreter of the senses, and the director of all movement. Lying in its bony shell and washed by protective fluid, the brain is also the most fragile organ in the body, with the same texture and consistency as gelatin. Within the brain are over 100 billion nerve cells, called neurons, sending electrical and chemical signals to and from the body. Each neuron has a cell body, a long nerve fiber called an axon, and projections of the cell body called dendrites. Dendrites extend out from the cell body to receive messages from other nerve cells. Axons in the brain connect neurons with each other, which in turn provide extensive interconnections with other brain areas. Because the brain and its nerve cells are so fragile, sudden, rapid movements of the head can cause injuries. During one such injury, called coup contre coup or acceleration-deceleration injury, the brain bounces back and forth against the bony interior wall of the skull. In high-speed coup contre coup injuries, the impact may be violent enough to cause swelling and bruising of the brain tissue, called a contusion. However, in cases involving low-speed coup contre coup injuries, the resulting damage may not be visible to the naked eye. As the brain moves back and forth within the skull, areas of varying density in the brain slide over each other at different speeds. Axons crossing these junctions experience tremendous shearing forces, causing them to stretch and tear from the cell body. This event is called axonal shearing, or diffuse axonal injury. Brain damage can continue to occur for hours or days after the initial injury. Damage to the axons can lead to a breakdown of communication among neurons in the brain. The torn axons quickly degenerate, releasing toxic levels of chemicals called neurotransmitters into the extracellular space. In turn, many of the surrounding neurons begin to die over the next 24 to 48 hours, worsening the initial effects of the injury. Mild to moderate cases of diffuse axonal injury, or DAI, may result in symptoms such as brief loss of consciousness, impaired long-term memory, reduced problem-solving ability, lower social inhibition, and problems with attention and perception. Severe cases of diffuse axonal injury may result in coma or a persistent vegetative state. In the United States, over 1 million cases of mild traumatic brain injuries, including diffuse axonal injury, are reported each year. Of this number, over 300,000 patients suffer long-term effects from the damage. Computed tomography, or CT, and magnetic resonance imaging, or MRI, are tests that can be performed to check for mild traumatic brain injury. The results of these tests usually show a normal reading. Therefore, doctors must rely on patient history and a clinical exam to diagnose mild traumatic brain injury.
Okay, so I want to really quickly talk about those symptoms. The only one that's really common, the only one that we can say, for sure is always going to be a symptom is loss of consciousness. It seems like that's the only thing that happens to every person. Because the brain is made up slightly differently for everybody, and because no injuries are going to happen in exactly the same place, the only thing that we know for sure happens is loss of consciousness. And of course, there's different amounts of time that someone can be unconscious for. Of course, the longer, the worse it is. But that's really the only main common thing that you'll actually see. So what can SLPs do? Well, for concussions, One thing that SLPs can do is you can actually monitor players for signs of concussion, because it does have a speech component to it. This is something that you can actually get a job doing, especially if you decide to at some point go through the neuroscience master's program. This could certainly be something that you can end up doing. So you can monitor for signs of concussion. There's a few different ways that we do this. I mean, there's a battery of tests that you can actually do. I think the NFL has their own battery of tests. MLB and all different sports agencies have their own battery of tests that you can do. And the things that you're looking for are things like confusion, omissions of words, omissions of letters, different things like this, problems naming objects, so like a tip of the tongue state and other things like that. You're going to look also at working memory deficits. So you probably remember this from, when did we talk about working memory? At some point last module. I've forgotten what it was. Anyway, and working memory is just your ability to hold information in short term while you're doing another task. We will talk about that more in the next lecture. One really important thing to know of is, where is the baseline? How can you tell that someone is, deficient in something if you don't know where they were to begin with? So how do you know? Let's say we're measuring something else. We're not measuring TBI. We're not measuring how bad a concussion is. We're measuring, can I run faster today? I drink 5-hour energy. Can I run faster than I did before that? Well, if we just measure my speed after I have a 5-hour energy and say like, damn, that guy's fast, it doesn't really say that it was the 5-hour energy. We have to have some sort of baseline. So we have to know where I was before I had 5-hour energy, which tastes gross anyway. Like, I don't even know why I brought that up. I hate anyway. So you have to know where the person is to be able to make a comparison. So when some of these measures started of testing for concussion and looking for deficits, we didn't have a baseline. And that doesn't really help us. So if we test somebody and we say, like, you're really bad at this working memory thing, do we know that they weren't really bad at the working memory thing? Or if they were really good at it, like really extra good, and they test and they're fine, but we don't know that they used to be like really good, we missed the deficit there. Now, this is something that the agencies know about. I mean, it's not that they may not have known about it in the beginning. It might have just been that before it wasn't something that we took seriously, then it became something that we took seriously, and they couldn't go back in time and get that data. So either they didn't know that they should have had it, or they just couldn't get it. It doesn't matter. Either way, it wasn't there. But I know that MLB and volleyball, I think USA volleyball, but probably, most college volleyball and things like that, possibly NFL, I don't actually know, test their athletes monthly for these cognitive tests. And so if you are one of these athletes, it's really important that you do your best at the cognitive tests. Don't take it for granted. Don't, just think like, why do you test me for this all the time? This is ridiculous. And then not put your full attention into it. Definitely put your full attention into it, because that's how you'll know if something is wrong later. And if something begins to go wrong later, you don't want to compound it with further injuries. You have to, stop, get tons of rest. You can't have a concussion on top of a concussion. It's worse. At least let the brain heal as much as it can before you get more. I mean, it's better not to get any, but obviously that's not always going to be the case. And then long-term effects is something that it's much harder to measure, right? I mean, we have immediate effects of concussion, like large concussions. We see that there's confusion right away. But very small concussions, multiple small concussions that might not cause an immediate deficit, could work together to create a deficit over time. And so that's another thing that we need to be mindful of. So if you go into this, don't just look at data from before this concussion and right after. Also, take a look maybe at your athletes for an entire year and see if any of them are declining. They should be staying about the same. If they're declining, that could be a sign that there's multiple small concussions and it's creeping up and building on each other. Okay, in the next lecture, we're going to talk about TBI and aphasias. Where's my mouse? There we go.